Good afternoon and welcome to this bill hearing for the House Health Committee. I ask for your patience if we encounter any technical or streaming issues. This briefing is being streamed on the Maryland General Assembly YouTube channel. Panelists will control any, no, we're not, I don't believe we have slides. Please note that food or beverages are not permitted in the gallery. Delegates may have drinks at their desks as these meetings can run long and hydration is necessary. If a member is not present in the horseshoe, please understand that they may be attending other official meetings or defending their bills in other committees, but are remaining informed of the proceedings. Please adhere to our committee rules of one question and one answer from the panel, not one question and one answer from each panelist. And please keep in mind to keep your questions brief and shorter than the answers. Additionally, our sponsor will not be time limited. Please make sure that you're keeping your testimony within reason. All other panelists will be limited to 2 minutes. For planning purposes, the order of the bills today will be House Bill 316, followed by House Bill 410, followed by House Bill 181. We will start with the sponsor panel and then move to a favorable, and then if we have favorable with amendments and unfavorable. And with that, Delegate Kaufman, welcome to your first bill hearing in the Health Committee.
Yes, I'm very excited. It's my first bill hearing as a member of the Health Committee. Thank you, Madam Chair and Vice Chair Cullison. For the record, my name is Delegate Aaron Kaufman, and I'm here to request a favor report on House Bill 316, Confidentiality of Medical Records, Definition of Medical Record as amended. In response to discussions with stakeholders, we have amended the bill to address concerns about scope and clarity. The amendment clarifies that only electronic messages related to patient care are included, ensuring that clinically relevant communications, including transcripts of audio or video communications, are preserved while excluding informal, administrative, or non-clinical exchanges consistent with the bill's patient safety and medical records transparency goals. This bill, as amended, addresses a serious and growing gap in modern health care. Under the current practice, patient charts tell only part of the story. Today, patient care decisions are frequently made through secure electronic messaging systems, with physicians consulting specialists, nurse confirming medication changes, or providers coordinating transfers of care. Yet many of these clinically relevant communications are never preserved as part of the patient's official medical record. What we are talking about is patient safety and patient care. Medical professionals are not texting each other in these secured chats with statements such as, "What would you like for lunch?" but are discussing sensitive medical information concerning patients. When these messages on these electronic text apps disappear, the clinical reasoning behind care decisions disappears with them. That creates risk for continuity of care, patient transparency, and patient safety, particularly when a patient is transferred to another facility and new providers must rely on an incomplete record. HB 316 establishes a simple and common sense principle. If a communication informs patient care, it belongs in the patient's medical record, simply. The bill ensures that clinically relevant messages exchanged through HIPAA-compliant systems are captured, retained, and accessible as part of the medical records. This legislation not only benefits patients, but medical professionals as well. Preserving these communications helps demonstrate a provider's commitment to patient care, especially during transfers between facilities, where clarity and continuity are critical. It also protects clinicians by documenting appropriate practices, sound clinical judgment, and decision-making, which is information that can be essential in the event of litigation or retrospective review. Importantly, the bill does not compromise privacy. Hospitals across Maryland now rely almost entirely on electronic medical records, which are stored and maintained by HIPAA-compliant third-party data centers. Medical records are legally the property of the patient, regardless of where they are stored. This bill simply ensures that that all clinically relevant information is treated with the same level of accountability. Secure messaging is already a routine part of modern medical care. A multi-state study cited by the American Medical Association found that across 14 hospitals and 263 outpatient clinics, more than 9.6 million secure messages were sent in just 6 months, while usage increasing nearly 30% as systems were fully implemented. Additionally, peer-reviewed research published through the National Institutes of Health shows secure messaging volume growing from fewer than 10,000 messages per month to well over 200,000 messages per month within a single health system. These findings confirm that clinical decision-making is already happening through these secure messaging chat platforms, making it essential that messages informing patient care are part of the medical record. You may hear concerns about data storage and operational input, but thousands of pages of images, labs, and other data are retained today without issue, and clinical messaging is often far less data intensive. EHR systems are already capable of archiving secure communications. This bill simply ensures that that capability is used. The integrity of the record should not depend on a hospital-by-hospital discretion. This bill is about patient safety, a transparency bill, and an accountability bill. At its core, HB 316 is a patient safety bill and a provider support bill. It strengthens continuity of care, improves transparency, ensures that medical records accurately reflect how care decisions are made. For those reasons, I respectfully request a favorable report. But before I conclude, Madam Chair, just very briefly, I want to talk about one particular case where these secure messages are often the difference between life and death. For example, the Maryland Association for Justice provided me with a case whereby somebody was experiencing a bowel obstruction, and a hospitalist kept sending x-rays and other imaging to another doctor, but nothing happened, and the patient died. So these communications are often the difference between life and death. Thank you very much. I'll gladly take any questions you may have.
Do you want to go ahead and introduce your panel?
Oh, yes. I'd like to introduce my panel. I didn't know the custom here at HGO. I would like Kieran Murphy, please, Chris Wright, Vincent Lopez, and Ms. Crystal Williams.
And if your panel wants to go ahead and get started.
Good afternoon, Chair Bagnall, Vice Chair Cullison, and members of the committee. My name is Christopher Wright. I have been a trial lawyer for almost 20 years representing victims of medical negligence. I come from a family of healthcare providers, physicians, nurses, and radiology technicians. I have the privilege of choosing which cases I investigate and ultimately pursue on behalf of individuals. I do not pursue cases where I don't believe there is very strong evidence that the healthcare providers acted unreasonably and caused serious injury or death. When signing up a new client, I make it clear to them that I can't promise that I will pursue their case, but I do promise that I will do my best to get them answers as to what happened to them or their loved one. Part of that process includes reviewing all of the patient's medical records to determine whether the medical treatment and medical decision-making was reasonable. All too frequently, I am reviewing hospital charts that state things like, quote, communicated with provider via Tiger Connect or in-basket messaging. Unfortunately, by the time these clients get to an attorney like me, which is typically more than 30 days after the care at issue, these messages are no longer available for review because the hospitals either set a short retention period internally for these communications or contract with outside providers who allow the messages to be destroyed after a short period of time. These decisions to allow the destruction of this crucial evidence prevent all individuals from getting to the truth of what actually occurred. I believe that the passage of this legislation will lead to less lawsuits because the evidence will either show that the healthcare providers acted reasonably with their medical decision-making, thus preventing the filing of a case, or it will show clear evidence that they did not act reasonably and hopefully lead to a resolution of the matter out of court. For these reasons, I urge a favorable report on House Bill 316. Thank you.
Good afternoon, Chair Bagnell, Vice Chair Cullison, and members of the Health Committee. My name is Kieran Murphy, and I am a legal advocate for patients. Every patient has a right to all of their personally identifiable health data. Not some of it, all of it. Unfortunately, the definition of what a medical record is in the state of Maryland has not been updated since the advent of the smartphone. Nowhere is this more evident than in the realm of ephemeral text messaging data, which is a subset of clinical information shared among healthcare providers about their patients. Some of these ephemeral text messages are stored directly into the patient's EMR. For example, Epic has something called Epic Secure Chat. Cerner, which is provided by Oracle, has Cerner Connect. And others are through third-party vendors, such as Tiger Connect. But what all of these ephemeral text messaging applications have in common is that they all auto-delete after a set period of time, generally 15 to 30 days. And second, they all deprive patients of the information exchanged between providers about the patient and their health care. Recently, CMS and the Joint Commission have approved placing orders via text messaging, making the adoption and incorporation of the proposed bill all the more important, because now orders are going to be placed through text messaging applications like the ones at issue, but there's nothing protecting a patient's right to see what's exchanged in those text messaging applications. At the federal level, although it has not been adopted in any sort of health context yet, formally, the FTC has issued guidance that indicates that entities need to store ephemeral messaging data like this for a certain period of time to make sure they can comply with investigations by the federal government. I think it's important to note that some of the letters submitted in opposition make comments about the need for the free exchange of information. And what I think is important for everyone to be aware of is patients' information, while it's exchanged freely, is still the patient's property. Thank you.
Good afternoon, Chair Bangle and members of the committee. Thank you for the opportunity to testify in support of House Bill 316. At the core of HB 316, that's a simple but frankly damning question. Why do our laws fail to protect patient conversations and determine life and death? Why are we deliberately leaving vital medical conversations in the digital dark ages? This bill answers that question with the clear and necessary yes, that it's time to stop taking risks with patients' lives because our laws are outdated. This legislation not only corrects the critical flaw in the current patient protection laws, but also lays the essential groundwork for future reforms. Healthcare today is no longer documented solely in paper charts or even traditional legacy electronic notes. Patient care is now unfolding across secure messages, digital communication, portals, and electronic platforms that are credible and crucial to the real clinical decisions we make every day. The scattering of patient information across countless vendors, platforms, institution undermines the accountability, fuels uncertainty, and destroys patient trust. This systematic crisis exacerbates by the established EHR companies whose proprietary and fragmented systems ensure their market dominance and financial security, generating billions annually from patient data, yet often failing to possess a comprehensive medical record. This prioritization serves their financial interest over the goals of the seamless patient care and robust data security. Modern health informatics differentiates electronic medical records, EMRs, from electronic health record, EHRs, a distinction crucial for patient data portability and quality of care, as detailed in Vijay Lopez, identifying the difference between electronic health records and electronic medical records, published in the IEEE Industry Connect report. Excuse me. While 316 deliberately solves the problem of defining the medical records, it is simultaneously exposing the crucial long-term challenge of patient data control and stewardship in today's fragmented digital environment. The current fragmentation in digital health systems poses significant risk to patient safety and the quality of care that is fundamentally an architectural flaw that lies within the electronic health record systems that do not seamlessly follow patient, and this continuity of care is compromised when treating patients. Thank you for your time, and happy to answer any questions.
Good afternoon, Chair Bagnell and Vice Chair Cullison. Thank you for having us here today. My name is Crystal Williams. I'm an attorney with the Public Defender's Office, and I practice in the Government Relations as well as the Mental Health Division. And we are here today in support of this measure on behalf of Delegate Kaufman because our support is quite simple for this bill. We see it as providing a necessary update in the era of where much of healthcare occurs through patient portals, telehealth platforms, and electronic messaging. Bringing these records clearly within the statutory definition ensures they receive the same protections as traditional paper charts and office notes. For justice-involved individuals, this clarity is not abstract. Medical records are routinely sought in criminal and mental health cases, probation and parole matters, child welfare proceedings, and immigration cases. When the law lags behind current technology, it creates gaps that can be exploited to obtain deeply personal health information with less scrutiny. This bill helps close those gaps. Under current law, medical record is defined in terms that reflect an older conception of healthcare documentation, focused primarily on information that is entered into a patient's record. The updates proposed by HB 316 importantly include information into the medical record that is recorded and not simply entered by a healthcare provider. This update reflects how healthcare is actually delivered today, where significant clinical and administrative communications occur via text messages, emails, and electronic health systems and telehealth platforms, where we know all of this information is being now ubiquitously used everywhere and is now infiltrating our healthcare system, and protections need to be put in place. Without this update, critical privacy protections may not apply to the full range of communications that meaningfully reveal details of a person's treatment, diagnosis, or care. Modern medical records are not confined to paper or static electronic charts. Many interactions from clinician to clinician consults to patient-provider messaging happen across all these various digital platforms. Protecting patient privacy is inherently a matter of justice and dignity. Sensitive health information includes mental health treatment, reproductive care, substance abuse treatment, and other deeply personal medical histories that must not be left exposed. And so we ask for a favorable report on this bill. Thank you.
Thank you very much for your testimony, and congratulations on your first bill hearing as a member of the committee. That said, do we have any questions for the sponsor or his panel? Okay. All kidding aside, do we have any questions from the members? I'll start with Delegate Hill, followed by Delegate Hutchinson.
Very much, and thank you, Delegate, for the bill and for having a conversation with me a little bit in advance, although I didn't get a chance to actually read it until today. Can you, before I ask the question, can you explain again to us what your amendment does?
Yes, let me pull it up, and just with your indulgence, I will get, what it does is it addresses, my mentor in the caucus is Madam Speaker, before she became Speaker, and she said, always work with the opponents of your legislation. So that's what I've attempted to do here. So this in particular addresses the concerns of Kaiser Permanente, where it talks about recorded a healthcare provider through written, electronic, or other means, including transcription. Transcription was very important for them. Then there was a lot of concern about extraneous messaging being subpoenaed and different things like that. And so it says electronic messages sent or received by a health care provider that is related to patient care and identifies or may readily be associated with the identity of a patient. So, I gave the example of, the people like Mr. Murphy here won't be able to subpoena text messages that say, what do you want for lunch? I'm headed to Panera. It has to be related to, the patient care, but I did send out the amendment in advance of the hearing, so I'm happy to talk to you more about it offline.
Thank you. So here's my question and my concern about the bill as written. My understanding is what you're trying to capture was reference third-party vendors and some of the primary electronic health record vendors who allow for formal communications of information, but then that information is auto-deleted. You are also capturing not simply things that would have been in a written record, but what this bill is capturing is conversations as they would have occurred 50 years ago. So as a provider, I might turn to Dr. Hutchinson and say, hey, this patient here, will you look at this x-ray with me? Tell me what you think. Never would be in the record, but that would be part of my conversation. Now, you're saying that that conversation that we've had, you now want access to. Some of those digital records are on my cell phone. They're not part of a hospital record, but they're part of my processing to determine what I need to do. This as written is capturing all of that stuff that is not part of the hospital record, stuff that is personal record of the provider, and stuff that is important to processing and determining what our actions are going to be. We never wrote everything down, but you're capturing everything, and I think that's problematic. And do you disagree with that?
Well, I defer specifically for your question to Mr. Murphy, but in general, anything that I think that you say about a patient should be accessible. So we can agree to disagree, but that's what I generally feel. But I think Mr. Murphy has something more to add.
Delegate, it's one question, one answer.
Oh, okay.
So I'm going to ask the question, Mr. Murphy, did you have anything additional to add?
If I may defer to my colleague, Mr. Wright.
Can I have a follow-up? Yes. Mr. Wright, did you have anything to add?
Yes, thank you for the question. And to answer your question, if you were to send a message about, come look at this x-ray with me, if you're not identifying a specific patient, then that would be okay to send through a text message on your personal cell phone. If you're identifying a specific patient, that's supposed to go through the hospital-approved applications. And those applications have to be HIPAA compliant. All of these vendors are HIPAA compliant. That those communications they're already preserved for 30 days. So we know that they can be preserved. The concern is that they're set to automatically delete after 72 hours or 15 days or 30 days. But you can still have those phone calls. This is not going to cover phone calls. It's not going to cover the conversations in the hallway. It's just the things that are reduced to writing about a specific patient that deal with that patient's care. That needs to be part of the medical record that is preserved.
The answer, let me suggest that's not how it's written.
Thank
Okay?
you.
Thank you.
Delegate Hutchinson.
Thank you, Madam Chair. I was actually going down the same path as Dr. Hill, Delegate Hill. I'm not a doctor, but the magnitude of the amount of data that I'm foreseeing being captured just seems the cost of healthcare will just rise in trying to get to this holy grail, what you're looking for. So I'm going to ask a different question. Delegate Kaufman, you used an example at the end of your testimony as to how that patient example, and I didn't follow your example and how this bill would apply to that. Could you elaborate?
Yes, I'd be happy to, Delegate Hutchinson. The Maryland Association for Justice provided me several examples of instances where if a doctor had paid attention to the secure messaging app, there would have been a different outcome for a patient. So my only thing is that this is why it's so important that this becomes a part of a patient's record, because The only reason they were able to get the records was under subpoena, and in many instances, that is not admissible. It depends on the judge. So I'm just saying that, you know, when we're trying to figure out what went wrong with a patient, I think everybody should have full access to what was written and what questions people have.
Thank you, Delegate. Thank you. I'm okay. Thank you.
Delegate Riley.
Thank you, Madam Chair. So we've heard there's a lot of different ways, text messages or videos or whatever, going back to looking at X-ray. So have you thought about how all of that information is actually going to be put together in one place and put on one particular system? Because I don't think, or there may be, is there a certain system out there now that all of this information a doctor or a physician or a hospital can put in?
Can I defer to Mr. Lopez?
All right, great. Sorry, so I'm Vince Lopez, again, founder of Parker Health. We are an EHR company. In terms of the EHR functionality, yes, there is a process in which we are obligated to comply with on the federal level with the Office of the National Care Coordinator that requires us to follow certain structures of data and standards that are required. Those all are applicable for us to follow in the same context that any data that is being transmitted through text messaging, through patient portals, through any other applications are required to be imported into the full EHR record and the patient file. And so part of this and where this bill is going is really to kind of codify that at the state level. There is federal requirements to it. There is some work that's being done at that level, and I'm happily engaged in some of that. But at the same token, it needs to be also mandated from the state level. And I think what the delegate here has proposed makes sense to start to bring in more of that discussion. In terms of one unified system of healthcare kind of records or data sets, no, there's numerous of them. There are two major players in the country right now, Oracle and Epic, and they have a huge market share. But the reality is that our data is fragmented for purpose of making profit versus over-serving our patients. And so what is happening is there is a number of other systems that feed into a electronic health record, like text messages, like x-rays, like lab results, that are all third party. And so they're fed into an Epic or an Oracle product or a Parker product, et cetera, and that then displays all the data. Within that, the actual issue at the base of it is that the data is fragmented, meaning that it's showing cache or iris data. So it's basically showing a very high-level scheme of data, but there's no data storage in the back. And so if you notice in some of the most recent court filings with other major competitors, Epic, for example, they have stated that they do not store or maintain patient records, and they put that onus back on the provider, the hospital group, and everyone else in between but themselves. And if you look at the way case law is written and what has mostly happened, the patient and the provider are the major owner of that data per what Epic and Oracle are saying. However, the system that is being held in the system of record should be the EHR platform that is required and obligated by federal law today to facilitate that transaction of data at all compliance levels and not be complacent and making patient data at risk. And what we see today is that there's no enforcement from the federal level, there's no enforcement from the state level to circumvent all these methodologies that these EHR companies are using to make profit and putting our patient and our lives at risk every single day.
Just kind of like a follow-up. So you're, according to what you just said, is that this is already a national thing by the feds, supposed to be being done.
Correct.
Clearly, we have information that, you know, the hospital physicians are not doing this now. So it's still the point of who's going to gather that data and who's going to be responsible for that cost.
The cost of data is insignificant at this point. The protection of data is what matters, and who's using the data is what matters. Right now, we have a number of things at the federal level known as Qualified Health Information Network, which is run by TEFCA, right, which is a massive data lake where data is constantly exposed and being used without our knowledge or consent as patients. And so things that we don't even want on the record that are there are being used against us. And so from the cost perspective of maintaining this, the cloud space is very much not limited anymore. There's a number of different clouds, private clouds. But the reality is that most of our patient data today is not in the cloud. It is sitting in the basement of a server in a hospital system, right? And so that data now can't be moved to a cloud because it costs more to move that data to a cloud, vice just putting it on the cloud in the first place. And so when you hear major EHR companies talk about hybrid data and hybrid models of where they're moving or not displaying data, the reality is it's not true because most of that data is relying and sitting in a server in the basement. Sure, thank you.
Delegate Rosenberg.
How often does the circumstance that you've given as an example occur in terms of this kind of harm to a patient, if not death?
Whoever's best to answer.
There's not precise data on that because we don't have the ephemeral messaging data to tie it to concrete harms. That's part of the issue here. As you probably saw, the Maryland Nurses Association is favorable for this bill, and part of what they put in their letter in support of the bill was the fact that very often nurses are conveying information that goes directly to patient care, and that's not stored anywhere that backs up the fact that the nurses brought concerns to the attentions of physicians or other healthcare providers. So to answer your question directly, we don't have an answer because the data is auto-deleted, right? It's similar to Snapchat. I mean, you put the data out into the ether and it's automatically deleted, and there's no storage being done over time. My understanding of the bill is the goal here is not to force third-party vendors to automatically incorporate into EMR systems that are separate and apart from it. But as I alluded to earlier, several of these ephemeral messaging applications are part of the overall EMR. Epic has its own that's built in. That data is just not being stored or archived. Cerner, which is part of Oracle, has their own ephemeral messaging application, which again is part of the EMR, but it's not being stored and archived the way that progress notes, radiology reports, the medication administration record, those things are. And what the purpose of this discussion we're having today is there are new forms of communication, provider-to-provider communication, that directly affect patient care that are not being stored or archived the way that other forms are.
May I tag on to that?
It's one question, unless Delegate Rosenberg wants to follow up.
I'm fine. Thank you.
Delegate Hill, did you have another question?
I think this is the only panel that's going to be able to address this. Thank you, Madam Chair, for your I appreciate the indulgence. So again, understanding what you said you're trying to capture, how is it that what you are also capturing is not the medical equivalent of, legal work product, which is not open to disclosure? This is medical work product.
I don't know that there's a recognized medical work product privilege in the state of Maryland. There is an attorney work product privilege that's recognized because it's sort of a corollary to the attorney-client privilege. And so I don't know that there's a medical work product privilege, but to try to answer your question directly, the idea is in EMR systems where there's an ephemeral messaging application built in, like Epic Secure Chat or Cerner Connect, those are tied to the patient, right? So you can see if nurse A messages Dr. B about a given patient, a lot of times that will be tied to the patient in the EMR. Not always, sometimes it's separate and apart. But if you take an example that I think is what you're trying to get to, which is the idea of if there are conversations, maybe they are not specific to a given patient in something like Tiger Connect, which is a third-party app. If the question is, if that's all being stored, how do we make sure that the mental impressions or conversations that are not specific to a patient, that are uniquely identifiable to that given patient, don't get disclosed? And that's where it would become a question of, once it's archived, it would be incumbent then when a request is made to the hospital, or to use the federal language, a covered entity, that would then, the onus would be on them to look at the time frame, correlate it with whenever the patient was admitted, and see if there is anything in that ephemeral messaging data, which under this bill would no longer be ephemeral. It would be stored and archived for the same statutory period. And it would also have no impact on the peer review privilege, because I think that is a recognized privilege in the state of Maryland, that if there are conversations that are meant to improve the care that's rendered because of concerns about care that was given, the peer review privilege could still be asserted by the hospital if a peer review process has been initiated. So the mental work product of the physician, so to speak, to the extent it's part of the peer review process, could still be protected. The hospital will still have the right to assert that. This wouldn't circumvent or abrogate the peer review statute in any way.
Thank you for the answer.
You're welcome.
About in subcommittee.
Yes, this will be going to subcommittee. But I have a question. in two parts. One, did you share the amendment with Kaiser Permanente ahead of this bill hearing?
I'm not sure. I have to ask my chief of staff, but I do know we shared it with the Maryland Hospital Association for sure.
Okay, thank you. And looking at the bill, it says identify or be associated with. And I think that language is perhaps giving us some pause. Because we don't have the amendment in front of us, does the amendment speak to the broader implications of be associated with as opposed to identified?
I believe it does because I could be wrong, but it narrows the scope of what is applicable and permissible. So I believe it does.
Yeah, I believe it does.
Okay, thank you very much to this panel. I'm going to bring up a favorable panel now. I have Jamie DeMarco, Emily Malarkey, Crystal Williams, and George Tully. Oh, wait. Christopher Wright. All right, who am I missing? Okay, I had Crystal Williams on there. Just want to make sure I didn't miss. Just want to make sure there isn't anyone else who is favorable on this bill that I did not call. What is your name? That's Jamie DeMarco. Oh, okay. Anyone that I didn't call. So I have Jamie DeMarco. So Crystal Williams just testified, correct? So Jamie DeMarco, Emily Malarkey, and George Tully then.
Do you want to go first? No, you should go. All right. Madam Chair, Chair Bagnall, Vice Chair Cullison, members of the Health Committee, my name is George Tully. I'm a trial lawyer. I let the really smart trial lawyers go in the first panel. So mostly what I'm going to say is me too. What I have a copy, I think, of the amendment, and so I could answer some questions about that if that's something you all care about. The purpose of the bill is, I believe, to change the way we talk about and think about medical records to reflect changes in the way that medicine is practiced. In the 1990s, when I started as a lawyer, medical records were whatever the doctor wrote down. And for sure, doctors had conversations in the hallway, and those were not in the medical record. In the course of events, the government decided that electronic health records was better, safer, and more efficient because it could be communicated and there would be advantages to doing it that way. And healthcare changed as a result of HIPAA, as a result of the advent of electronic health records, and now electronic health records are the norm, and the way that information is captured is different than it was in the 1990s. And I think that the definition of medical record in Maryland needs to reflect that. And that's what I believe this bill tries to do, and tries to do in a way that is just a modest change. It's not everything that anyone ever says about a patient. And as amended, it would be related to patient care. It would have to be, as the earlier panel suggested, identifiable patients. You don't just put a record that talks about cancer in every cancer patient's chart. If it has to be whatever the individual patient care is about. And those discussions, though, if they're reduced to electronic messaging, they're no different than a progress note, and should be part of the medical record. That's what we heard. The feds are looking at moving in that direction, but I like to think Maryland is a leader in healthcare nationally. I think you had a long hearing a couple weeks ago about that. And with that, my time is up. So thank you very much and I look forward to talking to you more about this sometime later.
Chair Bagnall, Vice Chair Cullison, members of the committee, thank you very much for the opportunity to testify. My name is Jamie DeMarco. On behalf of the Maryland Nurses Association, we urge a favorable report on House Bill 316. Our members, the nurses in Maryland, provide excellent professional care for our patients. And we are the front line who is most familiar with a patient and their symptoms. So if a course of treatment is causing a patient to lose sleep at night or to have issues with their bladder, our members are the most intimately familiar with those additional symptoms. And in passing those symptoms and effects of a course of treatment back to doctors and other people in the hospital, we believe that those are important medical records and that the insights from our members in our course of treatment and caring for the patients are insights of great medical significance and value, along with reports from lab results and other things. And we believe that the more there is a full record of the care of a patient that is part of the medical record, the more a complete story will be shared in court filings and other procedures. And we believe that that will not only provide greater vindication and support for our members and the decisions that we made and the decisions that the care team has made, but we think, as testified earlier, that there will be fewer lawsuits as a result. We urge a favorable report.
Delegate Hutchinson.
Thank you, Madam Chair. Mr. DeMarco, I agree with you that nurses provide exceptional care. But when they see those sort of things you just talked about, don't they go and put that in the medical records already?
There are times where I believe those reports are not made it into a patient chart under current operation procedures.
Then wouldn't that be to the detriment of the nurse doing his or her job correctly to put that type of information into the medical record?
If a nurse is communicating it to a doctor through something like TigerCom or some other messaging service, then it may not be the nurse's responsibility to make sure that that is put onto the patient's chart.
I don't agree with you on that, but that's okay. Thank you.
Thank you, Delegate Hutchinson. I'm just looking for any other questions. I have a follow-up on Delegate Hutchinson's question, because I think the overarching question we all have is we're speaking to what could be happening. How do we know that this is happening? Can you just speak to how we're identifying that this is a problem we need to solve?
We brought this to our legislative committee of nurses in Maryland and said, is this something that we would want to support? And, it was not easy for the committee, our legislative committee, to support this because, additional scrutiny on internal communications puts additional pressure on our members. But they identified this as something they did want to support because this is something they have seen where communications are made internally within a hospital that don't end up on the official record that end up being of significance.
Thank you. That's very helpful. Seeing no further questions, this concludes. Sorry, Delegate Riley.
Thank you, Madam Chair. It's quick. So I hear what you're saying. So how do you have a way of how this, if it became law, how would it be policed? And how would you know who would be liable, the nurse to give the information to the doctor or the doctor to give the information, or who's putting it up on whatever portal? I mean, I see it causing more problems in one incidence. So who's responsible? And how's it, I mean, we already heard how it's going to be done. So who would be responsible and who would be policing it, that the physicians and the nurses are doing it or not doing it?
Thank you for the question, Delegate. I'm not an expert on how this legislation would be enforced. My current understanding is that if a hospital used an internal communication system like TigerCom, then those communications going back and forth, instead of being auto-deleted after 30 days, would be part of a patient's chart and part of their medical records that would show up.
Thank you. All right, Thank you very much. This concludes this panel. We're going to bring up an unfavorable panel now. We have Allison Taylor, Jake Whitaker, and Larry Smith.
Madam Chair, if I may, Emily Malarkey is still in a Senate hearing, and that's why she's not here. It was not meant to be disrespectful, but she was signed up. She's unable to make it.
Okay.
I wanted that for the record.
Thank you for clarifying the record, because I meant to call her again. So thank you for that clarification.
Great. Thank you, Madam Chair, Madam Vice Chair, and members of the committee. I'm Jake Whitaker, here on behalf of Maryland's hospitals and health systems to testify in respectful opposition to House Bill 316. While well-intentioned, we are concerned that this bill, and even based on our first reading of the amendments that were shared this morning, we still believe that this bill may have a negative impact on patients' access and quality of care. We're concerned that this bill would create one of the broadest definitions of medical record in the country, because even with this amendment, the language is still subject to broad interpretation. This bill would redefine a medical record to include any recording by electronic means that would even remotely involve the patient. So for example, even with the amendments that we received today, routine hallway security footage where the patient walks through would have to be entered into that patient's medical record. This added data could obscure essential details such as allergies or medication conflicts, which will slow down care and just add unnecessary risks. Additionally, this bill would impose new costs for hospitals for things like servers or data storage resources instead of going to patient care. Also, under Maryland's unique hospital system, hospitals can't just raise revenue to adjust for new costs. So that's money that would have to go to data storage rather than to care. So that means that every dollar that we spend on data storage takes away from resources like addressing emergency department wait times or hiring new healthcare staffing. That said, even with these concerns that we've raised today, I do want to sincerely thank Delegate Kaufman and his team for scheduling time to discuss her concerns and really hear us out on multiple occasions ahead of the hearing today. But for these reasons, we do respectfully urge a favorable report on House Bill 316. Thank you.
Chair Bagnall, Vice Chair Cullison, and members of the committee, thank you for the opportunity to testify. My name is Jessica Costiva, and I serve as Associate Senior Counsel for HIPAA and Privacy for Johns Hopkins Medicine. I'm here on behalf of Johns Hopkins to respectfully oppose House Bill 316. Expanding the statutory definition of a medical record to include any information captured through electronic, audio, or video means rather than that information which is intentionally entered into the record of a patient would produce unintended yet significant adverse effects for patient care and safety. Such a shift would represent a major departure from the intended purpose of the medical record and introduce substantial conflict and ambiguity with existing regulatory frameworks. First, this bill would inflate patient medical records with irrelevant or misleading information. With this new definition, a patient's medical record could include everything from recordings of scheduling calls to security camera footage, draft notes, and internal communications based on conjecture rather than fact. Patients and clinicians alike would be forced to sift through thousands of pages of immaterial or inaccurate information to identify clinically meaningful information. Moreover, imposing an obligation to retain and produce this information in order to comply with record release requirements would create enormous operational burdens while offering patients only marginal value at best. At worst, this expansion would undermine clarity and make it harder, not easier, for patients to understand their care. This information is not saying, it was not to say that this information cannot otherwise be discoverable by other means. Perhaps most importantly, this bill would chill essential interprofessional communication and safety initiatives. Modern medicine requires teams to consult one another, to test hypotheses, reference texts, share uncertainties, and refine their thinking before finalizing a plan of care. But if everything said in that process becomes part of the legal medical record, not just discoverable, clinicians will understandably limit those discussions for fear it will negatively affect the patient-provider relationship or expose them to unnecessary litigation. They avoid candid conversations, limit outreach to specialists, and reduce the very collaboration that increases patient safety. Finally, this bill conflicts with the longstanding federal frameworks.
Can you please wrap up? Thank you.
That exist under HIPAA today. Thank you. And for that reason, I look forward to answering any questions you may have.
Sure. Good afternoon, Madam Chair, Madam Vice Chair, good to see you, and members of the committee. My name is Larry Smith. I'm Vice President for Risk Management Services at MedStar Health. But more importantly, I'm here because Chuck Connor and Kimmy Roston asked me to be here on behalf of MedStar. I have notes, but I'm actually going to deviate from my notes if I can, because I want to focus on Delegate Hill's comment and expand on that. By the way, before I do that, it's overly burdensome, it's ambiguous, I have no idea what we're supposed to collect. I think this bill needs a lot of reformation if we're going to consider doing it at all. Medical record has stood by for hundreds of years now and done us well, and now we're talking about doing something significantly different. We ought to think about it before we do it. But let me get to the issue of the process of care. Many of us have installed these secure messaging systems within our healthcare system to facilitate what Delegate Hill talked about before, which is the opportunity for every one of the members of our team to communicate with each other, even throwing against the wall ideas that may be not accepted as theories or suggestions or strategies for taking care of patients. Once all that is collected, there's an attending physician or a team of folks who make a decision about what is the most relevant bit of information to use in making the determination as to what should be done. That goes in the medical record. That's what belongs in the medical record. That's what the patient gets by way of treatment or medication or procedures or whatever else is done. All that other stuff is a process. And Delegate Hill mentioned, the issue of attorney-client privilege. Well, maybe it isn't physician colleague privilege, but if it isn't, it should be. Because as a patient, I want my physicians and my nurses to be able to exchange information, even if it's through technology these days, to be open and honest with each other, to question each other, to challenge each other, to come up with the right decision. It will have a chilling effect on our staff. I've already heard one colleague from one system say they will take Tiger Connect, which I don't use, out of their system because they don't want to have that kind of record be available because it doesn't represent what truly should be seen in terms of the issue. What I've heard more about today is not patient care, it's about liability and litigation. And I think that's really disappointing. This should be about safety, patient care, and what we try to do to make the patient safer and better in the process. Thank you very much, Madam Chair.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente, and I want to start by thanking the delegate and his staff for spending a lot of time with me on this bill and for preparing an amendment that was referenced earlier, looking at addressing a specific issue that Kaiser raised. I don't think the language quite gets there, but I do greatly appreciate the effort. So the thing that Kaiser Permanente flagged for me about this bill was actually not related to messaging, but related to another technology that they've started using called ambient listening technology. And so if a patient and a provider so choose at Kaiser, a medical visit can be recorded, audio recorded, for the purpose of creating a transcript of that the physician can review and upload as part of the medical record. Kaiser Permanente does not maintain those audio files. Those are very large files, and they're only created for the purpose of helping with the transcript. We think the way that the bill is written would require us to maintain all of that raw audio footage as well, which is what we think is of low value to the patient once the written record is created. So I wholeheartedly agree with my other colleagues here, including my colleague at the end of the table who wanted to flag that we do see that there is a potential conflict with the federal HIPAA governing statute and regulations as well. So thank you for the opportunity to speak.
Delegate Hutchinson.
Thanks, Madam Chair. My question is for Larry. Good to see you here today. So I found it interesting that everybody in favor of Bull were trial lawyers, with the exception of the nurses, which actually I'm perplexed by, actually. But they say this is going to reduce medical malpractice cases and it's going to lower healthcare costs. Do you see this reducing the number of medical malpractice cases coming up in the state of Maryland?
No, thank you, Delegate. Just the opposite. You know, we have enough to argue about sometimes regarding the outcomes when they're not favorable, whether there was malpractice or whether there was not. Now we're going to be debating the issue of what's behind the scenes in these discussions that go on with our providers as to what should have been considered along the way in terms of making. So I consider it to be an expansion, not a decrease in the amount of litigation that we'll see. And as far as the testimony by the representative representing the nursing staff, what I heard really was concern on their part about being sued, about litigation, about not having protection. But I think you identified it well by saying that the record allows the opportunity for those information to be in there for the protection of nurses and for physicians to express what they believe should and can be done for the patient.
Thank you, Madam Chair.
Vice Chair Collison.
Thank you, Madam Chair. So Allison, I'm looking at your testimony, and you, at the end here, you give us 2 potential amendments. If those amendments were part of this, is this something that would address your concerns and the concerns of your colleagues, or is there still more that has to be done?
I think those would, I put them forth. I think they go a long way to addressing Kaiser's concerns. I did not consult my other colleagues before I put them in, so I don't know that it would address everybody's concerns.
But it would go a long way for Kaiser?
Yeah.
Okay, all right. Thank you very much.
Yeah, thank you.
Delegate Hill.
Thank you, Madam Chair, and thank you all. First of all, Allison, thank you for working with Delegate Kaufman and offering an amendment. What I would like to ask, I guess it's in the form of a question, is why don't the 3 of you come up with something that you think will get at the delegate's point, which is that there are probably disappearing parts of the record that do speak to where you've given an instruction that you didn't follow, where you've shown something that you should have known about, that are different from the kind of work process communications that you addressed, Mr. Smith. So if you all can come up with an amendment that would narrow it to what it ought to be, as opposed to being as broad as, and that would be very helpful. So is that something you're willing to do?
You want to speak to it? We'd be happy to consider an amendment, but at this moment, I think we're just fundamentally opposed to the legislation. But as you mentioned, Delegate Hill, we'd be happy to consider any amendments, and we'd like to continue working with Delegate Kaufman and his staff as well.
Yeah.
Delegate Alston.
Try and translate from a friend over here. I think what she's saying is we're inclined to do something with this bill. We'd like to have your amendment and not us come up with it. So if you all could do more than consider and actually get us some language so you don't end up with something you don't want, it would be very, very helpful.
Thank you, Delegate Alston.
You're welcome.
All right, seeing no further questions, I think we have our marching orders. This will go to subcommittee. This concludes the bill hearing on House Bill 316. We're now going to move to House Bill 410, Public Health, Food, and Milk Product Labeling Requirements. Do we have Delegate Boyce here? Or
We do now?
oh. Perfect. All right. Delegate Boyce, you're fine. You can get started whenever you're ready.
Be nice if I turn this around appropriately.
Good afternoon, Chair Bagnall, Vice Chair Collison, and members of the Health Committee. For the record, I am Regina T. Boyce, representing HB 410, Public Health, Food, and Milk product labeling requirements. How many times have you paused before opening a package in the refrigerator, unsure whether it's gone bad? How many times have you reconsidered your morning yogurt because the food label reads that today is the end of its life, but your nose and your mouth tell you something differently? Every time each one of us sitting here today cleans out the refrigerator, we are making health, environmental, and safety decisions based on what we believe the food date label suggests is safe and/or of good quality. Sell by, use by, best if used by, best if used or frozen by, best before, packaged on, manufactured on, and expires on, all provide a hint or a suggestion about whether food is edible. Example, this has a date of maybe the 1st of this month. This will say, keep refrigerated, use by. This says, package by, use by. This says, enjoy by. And of course, our canned food says November 5th, 2027. We know that these varying food date labels do not have the same meaning. Yet, as a consumer, they cause great confusion that often leads to perfectly good quality food to be thrown away. HB 410 establishes requirements and prohibitions regarding food and milk product labeling and requires the Maryland Department of Health to create a marketing program and educational materials to inform consumers about the meaning of the standardized food date labels on food products. Updating and standardizing food date labels in this way would take the guesswork out of making determinations of whether food is safe to consume. Clear, standardized food date labels can help consumers save money, reduce wasted food, and keep food on their shelves. HB 410 was previously introduced in 2025 as HB 8 by Delegate Andrea Fletcher Harrison, a secondary co-sponsor of this bill. HB 410 will clarify food date labels with two simple, consistent terms: used by or frozen by, and also can be abbreviated as UB to indicate safety, or best if used by or best if used or frozen by, or BB to indicate quality. The term sell by will be removed or concealed from the consumer as the label is made only for retailers to determine when to rotate products in stores. Currently, there is a bipartisan federal legislation focused on this issue with the Food Date Labeling Act of 2025, Senate Bill 2541, currently in the U.S. Senate Health, Education, Labor, and Pensions Committee for legislative review. The bill, if and when passed, will standardize food labeling nationwide. From a national perspective, HB 410 was heavily modeled after California's AB 660 signed in September 2025, which is modeled after Senate Bill 2541, which requires uniform best if used by and used by food date labels starting July 1st, 2016, and eliminates sell-by dates. The commonality of HB 410, California's AB 660, and U.S. Senate Bill 2541 is the use of quality date phrases, best if used by, and discard dates used by. These bills have paved the way for states like Maryland to implement smart, consumer-friendly practices for food date labeling. Over 80% of Americans throw away safe, edible food due to confusion over food labels. The 2013 National Resource Defense Council, the NRDC, reports The Dating Game, How Confusing Date Labels Lead to Food Waste in America, says that it is estimated that per capita food loss is $390 per year, putting the total food cost for a family of 4 at $1,560 annually, and this does not account for inflation. One expert in consumer waste thought that figure was too low because it did not capture the estimated 10% of consumer food loss to garbage disposal. With that additional portion factored in, food loss could cost the average American family $2,275 annually. Food loss in the United States has been on the rise for the past several decades. Per capita food loss increasingly by 50% since 1974. In a survey from the Grocery Manufacturers Association, 85% of respondents said that it would be helpful if manufacturers shifted to using only 2 labels for safety and quality. When asked how the labels would assist them, survey respondents stated that the top benefits were feeling better about the food they eat, believing they would throw away less food, and saving money by throwing away less food, and increasing confidence in the products they use. Because of the consumer misconceptions that surround the meaning of date labels, the practice of open dating usually results in a higher rate of unsaleable and hence often discarded food for retail stores. In the United States, an industry initiative estimates that about $900 million worth of inventory was removed from the supply chain in 2001 due to date code expiration, and identified the lack of standardization around the date coding as one of the 5 factors driving that loss. Imagine that figure now. The U.S. Department of Agriculture estimates that over 1/3 of the food produced in the United States is never eaten, wasting the resources used to produce them, transport them, process, and distribute them. Further, most of the food is sent to landfills, where, of course, breaks down and generates to methane, a powerful greenhouse gas. Wasted food accounts for 24% of landfill space, much of it from unopened edible food. Because food date labeling has not yet been federally standardized, we can expect to continue to see inconsistencies across the country and more food wasted. I am hopeful that the committee will take the following considerations when reviewing HB 410. Clarifications about how we label shellfish. There is an opposition from the Consumer Health Products Association regarding labeling dietary supplements, which are federally regulated. This bill was not intended to standardize food labeling for federally regulated food and products. The committee will need to consider how this bill will affect the cottage industry, which, again, I will state, is not meant to harm the industry. The committee should consider what is considered too small as it relates to abbreviating the standardized food labels. That was a question that came up in discussion. How does the Maryland Department of Health education of food labels pass down to the retail industry beyond online posting? The NRDC recommendation is clear. A new system for food date labeling in the United States is needed. The system should have uniform language that clearly communicates to consumers the meaning of dates, as well as other food safety and handling information. The system should be the same throughout the United States for foods within the same category of products, and to the extent reasonable across all classes of food products. HB 410 aims to do just that here in Maryland. HB 410 will assist Marylanders with keeping edible food on the shelves and out of the landfills, and will divert good, healthy, quality food from the waste stream. By standardizing food date labels and providing education on what those labels mean, we begin thoughtful consideration for our planet, our health and pantries, and our wallets. Thank you for your consideration, and I urge a favorable report for HB 410.
Do we have any questions for this witness, for the sponsor? Delegate Hill.
Thank you very much, Delegate, for the bill. Can you, we're getting some pushback that it would be burdensome on retailers. Can you explain, you've already said that this would not be supplements. You're clear about what the products are. Can you, again, walk through what, I'm a mom and pop grocer, or I'm a big grocer like Giant or Safeway. What do I now have to do in Maryland when things come into my warehouse?
When it comes to your warehouse, you would no longer be able to, as July 2027, be able to sell those products. However, what you can do with those products that don't have the 2 coded labels is that you can, of course, sell, donate those products. So they wouldn't be products that would go to waste.
After the date, if this bill were to go in effect, when I get stuff from who's putting those sell-by dates on? Aren't they coming in with those on there?
That's correct. So the manufacturers would have to change those dates.
So the manufacturers would change them from Maryland?
Yeah.
Or else I, in my store, would have to write over them?
You would not be able to sell them, therefore you would have to donate those items. So we don't want to encourage wasted food, so they would be able to donate those products. They would not be permitted to sell them.
Okay, I'll follow up offline. Thank you.
Okay.
Delegate Shalega, followed by Delegate Riley.
Thank you. Thanks so much. Good to see you.
Good to see you, Delegate.
Do you realize what thin margin grocery stores operate on?
Can you put it in context to the bill for me?
So did you know
Delegate?
that grocery stores operate in a 1% to 2% margin, and donating food is, you know, they obviously have some waste with the perishables they sell, but how would your bill affect especially ma and pa small grocery stores? I have a few in my district, and I was, you know, of course, surprised to learn how thin the margins are for grocery stores.
Well, Delegate, I guess I would ask the question. I don't like answering a question with a question, but what do they do now when those dates come up for consideration, whether it's canned food or if it's a perishable food item? The question is, what do they do now if they don't sell those?
That's part of the reason their margins are thin. But you're talking about them receiving a pallet of food that was mislabeled, and now you want them to donate that food, when I think, you know, I would just ask you to consider and maybe talk to one of the small grocers about the challenge that this would present. Look, nobody wants to waste food. And maybe you could come over to my mother-in-law's house and help me clean out her pantry.
I'd be happy to. I'd be happy to. No, Delegate, I just want to follow up to saying I hear that, and I'm certainly open to having those discussions. I guess the question is there's a process in having to manage that currently. If you have food that doesn't sell by a certain time before they have to quote unquote rotate it, which is the sell by date that we talk about here, which has nothing to do with you and I as a consumer, right? So they would have that, and they would still be able to have that on those products, so they know how to rotate them. They just wouldn't be visible to me. So the question is I'd be curious to ask those small mom and pop places, what do they do now currently when it's time to rotate and move those products
Right, that's
over?
a great point, but you're
It'd be the
talking
same
about
process.
not expired food. You're talking about brand new pallets of food that come in and are mislabeled. Thank you, I won't
Thank
belabor
you.
it.
Delegate Riley.
Thank you, Madam Chair. So I'm kind of going to go on the back end
Yes.
with the donation, because I've been involved for many years with, you know, food pantries, food banks, Maryland Food Bank, all of those things. And I know that we have a great one in my district.
Yeah.
You know, it's where they get food from, maybe grocery stores or restaurant. I'm not sure where they get all of their products from, maybe right from the distributor. If the labels are expired, but they still know that the food is good. So that food does go to the food bank. And that food bank, I mean, feeds a lot of folks that cannot afford groceries right now.
Yeah, it wouldn't affect them.
So why would it not? Because you said.
Because they currently
would
do that.
I know, but if we had this law, wouldn't you?
No.
They wouldn't be expired. They wouldn't be on the shelves where the stores and the manufacturers would donate, because there would be no more food to donate, because now they've changed the labeling.
I don't think I understand the question. Could you ask it again?
I thought when I read your bill first, I'm thinking, well, is that going to eliminate all the food that's being donated to these food banks, which is very needed? So if we change the labelings, and there's, you know, where they have to rotate everything, and it's, so they're going to, I don't know, they might even have to buy in smaller quantities, which will be more expensive for our stores. There's not going to be anything excess that's going to have a date that may possibly be expired that they could donate to the food banks. You don't think there's going to be a
Delegate
problem?
Riley, why don't you go ahead and let her answer the
Okay.
question.
Well, she
So-
looked at me and like, she didn't, so I was trying to explain, sorry.
No,
So, yeah,
you're
I'll let
fine. I don't think that necessarily changed. So one of the things the food bank does now is they have an internal chart where they literally, when something comes in, they look at it and they make a decision based on the date that it's come in, whether it's something they purchased or whether it was donated, whether or not they distribute it out to their to those who need food. So it would be the same process that they do now. What this bill just says, instead of having 5 different labels, we're just saying we want 2. And so the process still in rotating that food would not cause any, it still manages the same process. They still would have to, if they got something in that says this date, right? This doesn't say anything. It just has a date on it. I don't know what that means. Is it best by or is it best if used by, right? And so that's the only thing that's going to necessarily change. It's not going to change how they potentially get food or how they'll be able to distribute food, because right now they make those determinations using a chart. Per my constituent who was kind enough to show me, they make these determinations now when they get food in to figure out shelf life, quality, safety. You know, if it's a canned good and it's an expired, I mean, we don't know if it's expired, but there's a date that said yesterday's date, they know per their chart that they can still give it out because it has X amount of a year or so still on it. So they do that on the back end. I just want to make sure I'm clear about your question. Are you saying that because of efficiencies, they would not get any more food?
Probably they would just rotate it more frequently, because I think they're going to have to buy quantities in a smaller amount when they go to their, their retail stores or their, manufacturers, because the dates are, may expire sooner.
Well, the dates don't expire sooner. All we're saying is we would like you to use 2 labels to label when food is safe and when food is just has less quality. We're not, there's no other ask.
Delegate Riley, we can get some clarity.
We'll just
through
afterwards.
the subcommittee process.
Thank you. Thank you very much.
Because I understand your concern, and I know that that a lot of the food banks and food distributions, they have their own internal systems, which often look very much like grocery stores, so we can get clarity for you. Delegate Alston.
Okay. So I was reading the bill, and it says that nothing will prevent these products from being donated to the food bank. So what we're doing is taking off the sell-by date and replacing it with those used by and best by date. I want to make sure I'm understanding before I ask my question.
That is correct, or whatever label folks use. We're saying that you have to have a used by or best by. And then in some cases where you can remove sell-by, or make it inconspicuous to the consumer and have it maybe in a QR code, for instance, for the retailer, so they'll know how to rotate food.
Got it. Now, my question is, why is there an exception for milk in the bill? I think that's about page,
There is, it includes milk as well. What page?
It says it doesn't apply to milk. Page 6?
Page 6. Page 6, line
9.
Does not apply to a milk product processed, packaged, and sold by the distributors directly to the consumer.
Or bulk shipments.
Or a bulk shipment of milk product between distributors.
Right, so with that, it seems like it's excluding milk from the bill. Or unless I'm not understanding. And we can talk about it more in subcommittee, but I am curious if there's an exception for milk.
I think it goes back to maybe the question Delegate Hill was asking about packaging. Yes.
Relabeling, okay. All right, great. And then, and I was just curious if our bottling companies had weighed in at all. I know we have some bottling manufacturers
I think the
here.
Beverage Association weighed in.
Okay. All right, great. Thank you.
Thank you. And I just want to look and see if I missed anyone. I just had one question, because it does call upon the Department of Health to create the programs. Can you just, I noticed they hadn't weighed in one way or the other. Can you just speak to your conversations with them, so we understand where we are in terms of?
I can't speak to those conversations. I can't speak to those conversations. I'm sorry.
Oh, that's right. No, we appreciate it. Any further questions? Seeing none, thank you very
Thank
much
you.
for your testimony. And we have one unfavorable panel, so I'm going to call John McLukey and Kaylee Locklear.
Good evening, Madam Chair and honorable members of the committee. For the record, Kaylee Locklear here on behalf of the Maryland Retailers Alliance. We are here respectfully in opposition to this bill. I want to thank the sponsor. We've been talking about this bill for months, so there's that. But I want to start just by clarifying an important point about sell-by language. It is standard language in our industry. It's a tool that's used by grocery stores to manage inventory, to rotate stock, and maintain consistent quality products on shelves. And we've discussed this in this committee many times, but from an operational standpoint, a state-by-state patchwork with new labeling requirements does create significant costs. When requirements differ across states, manufacturers must produce multiple versions of the same label, segregate inventory based on destination, redesign packaging, and adjust logistics and distribution systems. Those costs compound very quickly across the supply chain. Increased compliance and logistical costs are then ultimately passed on to consumers in the form of typically higher food prices. So at a time when families are already struggling with food inflation, these added costs do matter. And I just want to notate here about California, because California came up a little bit here. Milk came up. California exempted milk and egg products from similar requirements, and that's in part because of existing federal law, including the Milk and Milk Products Act. And that exemption reflects a very long-standing legal recognition that inconsistent state requirements can and do burden interstate commerce. This creates conflicting obligations for producers and retailers operating across state lines. Courts have consistently recognized this concern. We talked about it in this committee on a variety of issues. That's why food regulation is honestly one of the clearest examples that exist of why uniform standards across the country are important. I'm glad to answer some of these other questions that came up too. Food banks, by the way, do not accept expired product. They do accept sell-by products though, so I can talk about that later.
Okay, thank you, Chair Bagnall and distinguished members of the committee. My name is Robbie McLucky. I'm here on behalf of the Consumer Healthcare Products Association, representing the manufacturers of dietary supplements, over-the-counter medicines, and over-the-counter medical devices. I'd also like to add that I am a lifelong, proud Frederick County resident. First, I'd like to take a moment to thank Delegate Boyce for recognizing in her comments the exemption that we are requesting for dietary supplements. I'm going to get into the reasoning here behind that request. So while CHPA, we do support efforts to reduce consumer confusion around date labeling, House Bill 410 is not appropriate for dietary supplements and should not apply to them. The proposed date labeling framework is designed for conventional foods and quality-based dating. However, dietary supplements are fundamentally different products that are regulated under a distinct federal system and utilize expiration dating. In our experience with similar legislation in other states, well-intentioned legislation unintentionally captures dietary supplements. This creates a regulatory conflict and consumer confusion without improving safety, underscoring the need to clearly exclude supplements from food-focused date labeling laws. Supplements must maintain the full labeled amount of ingredients through the end of their shelf life. If a supplement no longer meets this labeling strength, even if it remains safe, it's no longer legally compliant and must be removed from the market. For that reason, supplements rely on FDA-regulated stability testing and clearly defined expiration dates, not quality-based terms like best if used by. Applying labeling that is appropriately designed for food to supplements creates a regulatory inconsistency. Finally, it's important to note that when California enacted a similar bill, I think it was in 2024, AB 660, the bill's sponsor did not intend for supplements to be included, and we are now currently working with the author through the rulemaking process to clarify and correct the scope of the law. House Bill 410 risks repeating the same mistakes same mistake, sweeping supplements into a framework that was never designed for them in the first place. For these reasons, we respectfully request House Bill 410 be amended and expressly exempt dietary supplements from the scope of the legislation. I've also submitted these comments for the record, my written comments for the record as well. Thank you very much.
Thank you. Delegate Kaufman, followed by Delegate Johnson.
Yes, I have a question for Ms. Locklear. It's always nice to see you.
Nice to see you as well.
I think that Delegate Boyce made a very compelling case about the different verbiage that is used and how that can be confusing for consumers. So if you don't like her approach, which I respect, what is the view of the Retail Federation? What's your approach to combating consumer confusion, or at least mitigating it?
So there are two main reasons that we label products. One would be safety and one would be quality. And so there are differences that are used in language. And I think something really interesting to me that's actually already included in the bill would be some sort of educational campaign around this. And we are really open to having those conversations so that there isn't consumer confusion that's occurring. But if I may just tack on to that a little bit, because we talked about consumers being confused, but this causes some confusion in grocery stores too. Sell-by has been used in our industry for a very, very long time. And I just need to point out that stores will err on the side of caution, and then they will discard items earlier if there is no way to identify them as potentially not being a safe product or a quality product anymore, or they potentially then would miss the rotation of a product, pull it late, and then that does become some sort of safety or quality issue. So there's another side and thought process that's going on the grocery side as well.
Thank you, Madam Chair.
Delegate Johnson.
Thank you, Madam Chair, and thank you for coming and giving us a different take on the bill. The question is for Ms. Locklear. You talked about standardized labeling. But is there honestly any standardized labeling with use by, sell by, best by, so on and so on?
There are variations in that language. So no, there isn't one standard that exists. This bill in particular only removes sell by the way.
All right, thank you. Thank you, Madam Chair.
Delegate Hill.
Thank you, and thank you, Ms. Locklear. So, similar question. You talked about manufacturers having to label. So there's the one label and there's a stamp label. Manufacturers, if I'm correct, don't they already do different labels of both types for different states anyway?
For sell-by, no. Sell-by is well known within our industry as a way to examine that internally, although we do recognize and understand that that can be confusing for consumers.
Okay, so because what I'm reading here says that the sell-by dates and best can be different by the same manufacturer in different states, but you're saying that's not true. Okay, so it's not really on the, if this bill were to pass, it would not be on the Maryland retailer to put a different date on. It would be the manufacturer who would have to comply with whatever our standards are, correct?
Except for the fact that we do have regional operators that do have private label in our region. So they are going to have to make a lot of the changes that I talked about because California law will not be applicable to them.
I'm sorry, but the labeling, like different ingredients and whether there are toxins and all that, that labels by state, so that would be, but the sell-by is not on that label generally. It can be, but it's a stamp on.
For the most
part. So they wouldn't have to change the whole label just to change the stamp, because they put a different stamp every day.
I see what you're saying.
Okay, they're not changing the label, they're changing the stamp.
That's correct.
Correct? And they're stamping them anyway.
Yes.
Okay, thank you.
All right, seeing no other questions, thank you very much to this panel. This concludes this panel and also the hearing on House Bill 410. It will once again be going to subcommittee. We have our final bill of the day, House Bill 181. This is the Public Health Restaurants Disclosure of Main Food Allergens. And Delegate, if you would like to bring your sponsor panel to the table.
Thank you. Would you like to come up? So where are you going to sit? Delegate Woods here? Yeah, that's good. Okay. Are you good?
You want to start, or you want to start? Introduce you.
No, you start. You start. Why don't you
Introduce you.
Yeah, you introduce me. Okay. Madam Chair, this was a bill that we combined, that the both of us brought, so I'm going to let Delegate Woods start.
Good afternoon, Chair Bagnell, Vice Chair Cullison, and esteemed members of the Health Committee whom I miss so dearly and am so happy to see today. You don't know how much this makes my day to be in this room with you all. I would like to, before we begin, to ask my well-respected co-sponsor, Delegate Foley, if she would go ahead and deliver her very brief testimony.
Thank you, Delegate Woods. Good afternoon, Chair Bagnell, so nice to say that, and Vice Chair Collison and members of the committee. So for the record, I am Delegate Linda Foley, and I'm testifying in favor of HB 181, as Delegate Woods said. This is a public health, restaurants, and disclosures of Maine food allergens. Well, I'll defer to Delegate Woods to speak on the merits and details of the bill. I would like to share briefly about how Delegate Woods and myself came to working on this issue together. Last spring, Sky Cushing, a student in my district, contacted my office regarding her research and effort to disclose food allergens on menus. She's a high school student, and she shared with our office her own personal experiences, which you will hear about today in her testimony. And after working with several advocacy groups and speaking with the Restaurant Association of Maryland, we crafted legislation to address this important concern with a simple and not burdensome solution. We also spoke with the Maryland Department of Health, who let us know that this would be absorbable as an operational impact. And then, because great minds think alike, I later learned that Delegate Woods shared almost an identical bill, and our offices have been working together to merge the bills and collaborate on this legislative effort. So thank you for your time considering this bill. And I just want to say that I'm incredibly grateful to Sky for bringing forth this issue with a common sense, easy solution. And it's for that reason that I urge the committee to give a favorable report on HB 181. Delegate Woods.
Thank you. Good afternoon again. I am here to request a favorable report on House Bill 181, legislation that simply strengthens consumer protection by ensuring transparency around the 9 major food allergens in restaurant meals. As policymakers, we have a responsibility to protect public health while respecting the realities of small businesses in the food service industry. Excuse me. HB 181 strikes that balance. The bill is not about placing new or unreasonable burdens on restaurants. It's about ensuring customers have clear, accessible information about what is in their food and how it is prepared, so that they can make informed decisions about their health and safety, and to ultimately prevent emergent, potentially life-threatening incidents unnecessarily. This legislation was informed by the voices of constituents like Sky Cushing, and who's here with us today and who you'll hear from shortly. Sky reached out to Delegate Foley, as she said, due to her own experiences living with food allergies. Her advocacy and lived experience were instrumental in shaping this initiative and underscores why transparency in food preparation matters to so many families across our state. Food allergies can cause serious medical conditions. I speak not only as a legislator, but as someone who has 8 out of 9 of the major food allergens. I experienced a serious reaction in a restaurant in spite of verbal assurances that the food I was eating was okay. And so it's imperative that we make sure that we carefully evaluate our meals so that we do not have those potentially dangerous reactions. Unfortunately, under current practice, customers are often forced to rely on those verbal assurances, incomplete ingredient information, and what turns out to be guesswork when ordering meals. This lack of clarity creates unnecessary risk for individuals and families navigating significant daily challenges to protect their health. No one should be subjected to unavailable or incomplete information that could possibly compromise, sometimes irreparably, their health and well-being. HB 181 provides a reasonable and flexible solution. It requires restaurants to disclose the 9 major food allergens using written materials, whether on menus, on digital platforms, using QR codes, allergen charts, or other written formats already familiar to the industry. The bill doesn't require restaurants to reformulate recipes, guarantee allergen-free kitchens, or adopt costly new systems. It simply asks that information the restaurant reasonably should know or already knows be made available to customers in a clear and consistent manner. It should be noted the restaurant cannot be held accountable if the customer does not acknowledge an allergen once informed. This legislation creates that trust between the seller and the consumer. Customers should not have to interrogate staff or fear that a misunderstanding could result in a medical emergency. Clear allergen disclosure empowers consumers, protects restaurants from avoidable harm, and promotes safer dining experience across the state of Maryland. HB 181 aligns Maryland with federal definitions of the 9 major food allergens, excluding prepackaged foods already subject to federal labor requirements, and reflects a thoughtful, measured approach to public health policy. Finally, it should be added that an amendment will be put forward to formally add the name Clear Labeling for Essential Allergen Risks, or CLEAR, to this bill. It should be noted more than 25 professional organizations support this bill, and for this reason, I respectfully urge the committee to issue a favorable report on House Bill 181. Thank you so much for your time and consideration, and the pleasure of seeing you all again.
It's a pleasure to have you back in our committee. Before we go on, I just want to make sure that I am clear. You have 7 on your sponsor panel plus 3 virtual who are also on the sponsor panel. Is that correct?
I believe that is correct.
Okay. I just wanted to make sure. So if you could make sure that you state your name, because we want to make sure that we have the record clear. And if I could ask you to go ahead and bring the sign down. We do have it on the record now. Thank you very much.
Yeah. Can we move to Sky?
Yeah.
Thank you.
Go ahead, Sky.
Hello, my name is Sky Cushing, and I am a junior at Wootton High School in Montgomery County. I've been allergic to eggs, fish, and nuts my entire life. Because of this, eating at restaurants is very difficult for me, as I have to play a game of telephone with the server, kitchen, and chef to find out what options on the menu are safe for me to eat. Even after this time-consuming process, I can still be left with uncertainty or information, causing me to have an allergic reaction. For example, a few months ago, I was at my friend's birthday brunch, and after about a 15-minute process of trying to find something on the menu I could eat, I was assured that the breakfast burrito was safe for me. When the burrito was brought back to my table, I took a bite, and an allergic reaction quickly set in. My throat and mouth became itchy, and I had an unbearable stomachache, making it so that I had to leave. Because of this miscommunication, I had to miss out on celebrating my friend's birthday. I'm not alone in this frustrating issue. Over 600,000 people in Maryland have food allergies, making it unsafe and difficult for them to dine out as well. The implementation of House Bill 181 will eliminate the game of telephone and allow everyone in Maryland with allergies, including myself, to make safe and informed choices about what they eat at restaurants. I am in strong support of House Bill 181.
All right, and we have Sky's mother.
Hi, everyone. My name is Elena Christopher, and I'm the proud parent of Sky Cushing, food allergy sufferer, and policy advocate for House Bill 181. So, do you know what the parents of food allergy sufferers want? I'll tell you, we want to eat at more restaurants. I have 2 children, in fact, and they both suffer from life-threatening food allergies. I assure you, they are both tired of my cooking. We yearn to eat safely at restaurants. However, most of our restaurant experiences are challenging and put my kids at risk. This is because there is no standard food allergy labeling in Maryland. In the limited cases that we do go to restaurants, our normal course is to ask the servers if menu items contain food allergens. The most common responses that we receive are, I don't know, I don't think so, or let me check. We appreciate all of that effort. However, no one is ultimately happy in this scenario. The servers are given an impossible task of serving as a go-between the kitchen and our table, with the significant burden of keeping my children alive. And even when we do get assurances that the food is safe, it often is not, just like that brunch story that Sky shared with you moments ago. We just simply cannot dine in confidence. There has to be a better way. We believe this better way is House Bill 181, having accessible, easily to access, that's what I mean by accessible, just something as the delegates were indicating, that you could just simply access and have the information you need. Having accessible food allergy labeling will allow potential diners like Sky and the other more than 600,000 people with food allergies in the state of Maryland to dine safely in restaurants. This bill supports both those with food allergies and restaurants who want to expand their dining population. Please join me in supporting House Bill 181 and let food allergy sufferers dine safely in Maryland. Thank you.
I guess this is our first panel.
I was going to say, do you want us to take questions, or do you want the full in-person panel to go?
It's up to you. We can take questions.
All right, let's go ahead and take questions from this part of the sponsor panel. I have Steve Johnson, Delegate Johnson.
Thank you, Madam Chair, and thank you for bringing the bill. I can see where restaurants would be a little spazzed out, thinking they're going to have to change all their menus and the costs involved. In the bill, I'm not really sure if it's clear as I'm reading it. So the disclosure, could that be just on a plaque when you enter the restaurant, so they would not have to change all of the menus, but just one plaque with the QR code?
Yes, sir. So clearly they would not have to change their menus, because they could, my suggestion would be, and it's certainly not expensive, that they could have a little placard on the table with the QR code. Some of the restaurants that I frequent, one of them being Silver Diner, for example, actually has a notebook that they can bring to you that has every allergen that they have on their menu in that notebook, and you can look at it for yourself. We are not saying that you have to change the menu to put it on. All we're saying is that somewhere you have to have the information available to a consumer, and we're recommending, which a lot of restaurants are doing now, that the server ask if anyone at the table has food allergens.
Thank you. Thank you,
Yes,
Madam
sir.
Chair.
Delegate Hutchinson, followed by Delegate Hill.
Thank you, Madam Chair. Delegate Woods, you certainly brought this to my attention when I had a crab feast for our committee at my home. And I think I served everything that you were allergic to, except for my super salad, which
was amazing.
Which I actually had in the back today, so you missed that. I'm sorry.
I haven't had lunch today.
So, does this bill apply to all restaurants, regardless of their size? And I empathize with you, and I see it, but I'm just thinking about, like, my poor restaurateur that is in Cambridge that is trying to keep the doors open and the staff, and then he forgets to update a QR code. And so does it apply to everybody? And then what are the penalties and fines if somebody doesn't do this properly?
So there are fines and penalties, but before I say that there are fines and penalties, what I can say is your restaurant in Cambridge, is it a large restaurant?
Single, small, it's not a national chain, it's just a small, maybe, 10-table
And
independent
normally,
restaurant.
we have found out through research that restaurants like that don't frequently change their menus. So it's not like it's a big deal to just have a QR code or something written in a book and ask somebody if they have allergens. The foods that they receive, they have to have allergen information on them already. Sure.
Yeah, there are requirements, Delegate, in the back room for dealing with allergens. It's just that there's not a public-facing notice about what those allergens are. So, as Delegate Wood said, it can be a very simple notification. And she used the example of a placard on a table. It could also be a poster on the wall where you walk in. It doesn't have to be, and the bill says this, it doesn't have to be something elaborate that you have to change all the time. The beauty of a QR code is you can go online and change it if your menu changes.
Easily.
If you have to add or subtract allergens.
But just to protect that small restaurateur, couldn't he or she just say, you have the possibility of being exposed to everything in my restaurant, and realizing he may or she may lose customers as a result, but that would suffice?
That would suffice, and I doubt very seriously that people would lose customers because I'm assuming that they already have a consistent customer base. Is that correct?
Correct. Yeah.
I don't think it would have that effect. I think that we're seeing more people participate in restaurants when they know. For example, I gave you Silver Diner. I know myself and other people go there frequently because they list all of their allergens.
Just one follow-up on that, but in that case, Silver Diner is a larger
Correct.
organization. I'm just
Who
worried
changes
I'm just worried about the
their
small.
menu frequently.
Yeah. Okay. Thank you. Thanks for bringing the bill up. Thank you.
My pleasure.
Delegate Hill.
Thank you, Madam Chair, and thank you, delegates and witnesses for bringing the bill. You're not going to get a chance, so I'm going to ask the questions. There's a restaurateur that has some concerns, but I will say they also have some amendments to offer. So they raise their concerns in the other. And they speak to frequent ingredient substitutions, vendors change that may alter allergen profiles without notice, shared kitchen environments, make cross-contact risk, and daily specials can also change what the allergens are. So the question is, they also say that the restaurant should reasonably should know is a really high standard. So we'll talk about all the amendments in subcommittee, but would you have any objection to taking out the reasonably should know standard?
I'd be happy to have a discussion because when we say reasonably should know, and Delegate Foley, if it's okay, can add, Madam Chair, no, she cannot, I'm sorry. Reasonably should know, thank you so much. Reasonably should know is what we said earlier, that the foods that they receive already have allergen labels.
So we would need to define that to say, if you've been notified of it, you need to pass it on to your customers.
Certainly, we would be willing to make that amendment.
All right, thank you. Thank you, ma'am.
Thank you.
Delegate Alston.
Thank you, Madam Chair. I just wanted to say, Skylar, you did an amazing job today.
Yes.
And thank you for your advocacy.
Thank you.
And I just wanted to ask, was there anything else you wanted to let the committee know?
You?
Yes.
No, thank you.
Great job.
All right, seeing no further questions, we're going to continue with our sponsor panel. And I have on my list Alexa Jordan, Sydney Greenberger, and Elizabeth McGrath Craig in person, and then we do have 3 virtual witnesses as well.
I was told that I could sign up and Barbara Hofstein. Do you have me on that list?
I have you on the favorable. I didn't have you on the sponsor panel. So we're just doing the sponsor panel right now, and then we have we'll go to an unfavorable to be fair, and then we'll go to a favorable.
Thank you, Chairwoman, and thank you, committee, for being here. I know it's late. My name is Alexa Jordan, and I'm here on behalf of the Asthma and Allergy Foundation of America, and I want to start with a brief personal experience. The first time that I can remember experiencing an anaphylactic reaction, I was about Sky's age. I was 17 years old. I'd just come home from a long day of extracurriculars and took a bite of a basil pesto sandwich we picked up from a new restaurant. Almost immediately, my mouth started to tingle and my throat began to burn, and suddenly I couldn't breathe. I didn't know that basil pesto often contains cashews, which is my most severe allergy. After frantically calling the restaurant to see if the sandwich I'd purchased had nuts in it, finding out that pesto has cashews, I used my epinephrine and went to the hospital. I remember that on the way to the hospital, I gripped my mom's hand and said, "Mom, am I gonna die today?" No child should ever have to ask that question, especially when there is such a simple intervention that could have prevented that entire reaction from happening in the first place. That basil pesto could have been labeled with a clear symbol or letter indicating that it contained nuts. That simple system of written allergen labeling has been in place for over a decade in more than 30 countries around the world. The UK, the EU. Why? Because restaurants are the highest risk setting for allergic reactions. And by implementing the system, less kids end up in the emergency room. HB 181 is a bill about clear communication. Right now, customers, as you've heard, must rely on conversations with waitstaff who often start with little to no information about the allergens contained within foods, and I don't blame them. HB 181 gives both diners and waitstaff a written foundation so that they can have more informed conversations to best limit risk and limit liability. Further, people who live with allergies are well aware that conversations to prevent cross-contact will always be necessary, with or without HB 181, because, as the delegate mentioned, cross-contact is sometimes hard to avoid in restaurants. So you need to continue to have that open line of conversation. Overall, we see HB 181 as a responsible step that all restaurants of every size can take to protect Sky, Delegate Woods, and the other 600,000 people in Maryland with food allergies. Thank you.
Sydney Greenberger?
Yes. Thank you, Chairwoman. My name is Sydney Greenberger, and I am a lifelong resident of Maryland, and I'm also here on behalf of the Asthma and Allergy Foundation of America. In the past week, our organization has received 25 signatures on our joint letter of support for HB 181, including from the Maryland Public Health Association, the Nurse Practitioner Association of Maryland, and the Maryland chapter of the American Academy of Pediatrics. This support from national and state-level organizations reflects the widespread interest in improving restaurant safety in our community. Communicable pathogens like E. coli and Salmonella, along with other adulterants that make people sick, are tightly controlled by dining establishments of all sizes in Maryland. Yet, the Department of Health fails to set up adequate guardrails for a particular set of food hazards that could cause very serious sickness and, in rare cases, death: food allergens. It's time that we address this glaring gap in public health here in the legislature to protect the 600,000 Marylanders with food allergies. Because there is no cure for this chronic disease, those affected must abide by strict avoidance. However, avoidance is particularly difficult when you do not know what's in your food. People with food allergies want to dine out at restaurants of every size, not just chain restaurants. AFA's parent survey report found that 90% of food allergy parents completely avoided certain restaurants. With allergen menu labeling, more food allergy families will be able to dine out. Ritesh Patel, the board chair of our nonprofit, has been a small restaurant owner for 16 years. He told us that it took him 2 hours to sit with his chef and redesign his menu to include the top 9 allergens. This 2-hour investment does not seem like an unreasonable inconvenience to avoid preventable deaths and severe reactions for a large portion of our population. Because of HB 181 and your leadership on written allergen information, we hope that more Marylanders will be able to dine out and support our local restaurants. Thank you.
Thank you. Great timing. And Ms. McGrath, Craig.
Thank you. Madam Chair, I will tell you that I don't have a polished thing written out, so I'm going to do the best I can. Thank you for your indulgence in that. I'm extremely grateful to be here, and thank you for your time and staying so late about something that I have basically not slept over for 16 years. So in 2010, I started a company called Menu Trimpo. We are one of the sponsors of HB 181 from the community. We moved our company headquarters to Howard County, Maryland, just over a year ago. So we are in Maryland. I graduated high school in Howard County, Maryland. So We started Menu Trimfo to provide nutritional information for restaurants and allergy charts. We've been doing this since 2010. So you absolutely can't tell me it can't be done. I'm telling you it can be done. Whether it's a small mom and pop restaurant or a chain, it easily can be done. And I say easily because the nutrition information and allergen tagging is on the back of every package that comes through your loading dock. People should not be going to the emergency room for dessert. They should be able to eat comfortably knowing they get to go home with their family the way everyone else does. And that is, I mean, I obviously already see my passion in it. No restaurant, big or small, in Cambridge, I'm wondering if it's my Italian place I love with the Detroit pizza in Cambridge, my favorite place. Even the small guys, you cannot afford to ignore this customer. 25% of people have food allergies or special dietary needs. And it's pretty prevalent throughout the country, and the increase has doubled and almost tripled in the last 15 years. So to say I can't serve you because I'm a small guy and I can't accommodate, you're already serving them. And unfortunately, an accident of this kind can cause someone to lose their life, not just go into anaphylactic shock, but end up dead, and that is a restaurant-ending event. One chain, one location, or 101 locations. So today we do nutritional information for restaurants all across the country. Big guys, small guys, chains are up and down the road here in Annapolis, but our first restaurant was a small Italian restaurant here in Annapolis that we did. So I just want to say it can be done. It can be done fairly simply in a multitude of ways. Thanks.
Thank you very much. Looking for questions for this panel. Delegate Gazzoni.
Thank you, Madam Chair. I'm going to direct this to Ms. Craig. It's a little bit off topic, but I think goes to the larger issue. I have a good friend who has celiac disease, and fairly significantly. She was traveling in Italy and found that every restaurant she went into was incredibly clearly marked, including being able to share that the pasta was 100% gluten-free and was cooked in a separate way and all that kind of stuff. So just in a larger sense, this kind of thing could probably be done in other sort of areas of menus as well. And obviously, tons of restaurants have vegan markings and vegetarian markings and gluten markings and non-GMO markings and all that kind of stuff. So just your comment on that.
So great point, and it speaks to other countries are well in advance of us here in the U.S. about it. There is a groundswell of this happening in the United States to meet these needs, and the groundswell that's happening is about radical food labeling. We're seeing it across all food right now. Some of it's coming out of D.C. The bottom line is identifying what is in the food to make it safe is different than saying it's kosher, is different than saying it's vegan, unless somebody's assuming vegan means dairy-free, which you would expect, but isn't necessarily always the case. So we are seeing a huge push from the consumer's desire for this, and Italy's a great example. You know, in Italy, they sell gluten-free food in the pharmacy. They consider it medicine. And there's something with FDA right now, an open comment period, talking about identifying the different types of gluten. There's 4 types of gluten that aren't identified and gluten-free, and there's an 11-year-old in Pennsylvania pushing for this to get it labeled on all labels of packaged foods. This addresses people that want to eat out next to their friends and enjoy a birthday party. That broke my heart. I just think we can elevate it to get equal to what people are doing in other parts of this world outside of the U.S. Great point.
Thank you, and thank you, Madam Chair.
All right, seeing no other questions, we are going to go to our virtual panel, which are still part of the sponsor panel. Then for equity, we will go to an unfavorable and end with our final favorable panel. So I have on the virtual, thank you all very much for your testimony. I have Nissa Shafi.
Yes, thank you so much.
Yes, but I did not have them on the sponsor panel. They're favorable, but they're on the favorable panel. So Nissa Shavi, Robin Lau, and Aaron Malawar. And Ms. Shafi, you can get started.
Thank you. Greetings, Madam Chairwoman and members of the Health Committee. My name is Nissa Shafi. I'm the Director of Advocacy at the Allergy and Asthma Network. The Allergy and Asthma Network is a national nonprofit patient advocacy organization dedicated to protecting and improving the lives of individuals impacted by food allergies and asthma. I'm here today to urge a favorable vote on House Bill 181, the Disclosure of Main Food Allergen Bill, introduced by Delegate Woods and Delegate Foley. The legislation addresses a critical gap in the public health code regarding restaurant safety and food transparency. For over 30 million individuals living with severe food allergies, a simple meal can result in a life-threatening emergency if allergen information is not clearly communicated or identified. HB 181 provides a common-sense solution to this problem through 3 key provisions. First, mandating disclosure. The bill requires restaurants to provide a written disclosure of each main food allergen that is an ingredient in the menu item. Second, ensuring clarity. Using common names of allergens or standardized pictograms on menus ensures consumers can make safe, intuitive, and informed choices. And third, prioritizing business flexibility. Restaurants may satisfy food allergen disclosure requirements in the way that best fits their operations through options such as a standard menu, a digital format like a QR code, or supplemental materials like allergen charts, booklets, or grids. If enacted, HB 181 is scheduled to take effect in October 1st, 2026 of this year, giving Maryland's vibrant restaurant industry ample time to implement these life-saving disclosures, positioning the state as a leader in food safety. Allergy and Asthma Network respectfully urges a favorable vote on HB 181 to protect consumer health, prevent unnecessary illness or death, and support Maryland businesses in providing safe dining experiences. Thank you.
Thank you very much, Ms. Shaffey. And if you can just remain while we finish out the virtual panel, in case there are any questions. Do I have Robin Lau? Okay. Let the record show that we call for Robin Lau. They are not in the waiting room. How about Erin Malauer?
Yes, I'm here. I don't have a camera. Okay, start video. There we go.
Okay, go ahead and start.
I think it can't start my video, but I hope you can hear me. Hi, my name is...
We can hear you. Go ahead and start.
Okay, terrific. There we go. Hi, my name is Erin Malauer. I'm the Executive Director of Allergy Strong, a national nonprofit supporting those with food allergies focused on underserved and at-risk communities. I'm also the parent of a 21-year-old with multiple food allergies who has endured the many challenges and appreciated the many benefits of eating in restaurants his entire life, and we are in favor of HB 181. While 1 in 10 people have a food allergy in the United States, study shows that 1 in 4 avoid allergens when making decisions about food. That's over 1.5 million Maryland citizens and 85 million Americans nationwide who are directly or indirectly impacted. Safe dining is a huge unmet need amongst people with food allergies and related conditions, as well as those who share meals with them. Why? Restaurants serve several functions. Restaurants are places to conduct business, a joy and a necessity of travel, a place to relax and socialize, to expand our minds and explore new cultures and cuisines. But they are also lifelines for those who do not have time or resources at home to prepare meals, those without access to a kitchen, those with limited access to neighborhood supermarkets, those who lack funds to buy fresh ingredients, and others. Restaurants are a necessity for many families. According to the CDC, 1 in 3 people report having reactions at restaurants, including my own child. We have data that restaurant allergen labeling works. A 2020 study found that of the total allergic reactions that were triggered by dining out, over 50% occurred even though patrons discussed their food allergies with restaurant staff. However, reactions were reduced to less than 14% when both allergens are listed on menus and diners discuss their food allergies with restaurants or staff. And while large chains already often make allergen menus available, we need this allergen labeling across all restaurants to move the needle in protecting the public. We also have some data that shows that HB 181 benefits restaurants. As an example, P.F. Chang saw a 140% increase in sales after introducing its gluten-free menu in 2010. Allergic diners are just some of the many patrons who would benefit from the consistent allergen labeling outlined in HB 181, and we encourage Maryland to embrace and protect its citizens by passing it into law. Thank you so much.
Thank you very much for your testimony. We're going to call Robin Lau one more time.
I actually heard from Robin. She's a nurse and she's in clinic seeing patients at the moment.
Well, thank you very much. She was here, but not able to be here for the testimony, so thank you. Do I have questions from the committee for our virtual witnesses? All right, seeing none, thank you very much for your testimony today. That concludes the sponsor panel. We're now going to go to an unfavorable panel for balance, and then we will go to our final favorable panel. So if I can call Sarah Price and Melvin Thompson. Go ahead and come to the table. And as soon as you're ready, you can get started.
Thank you, Madam Chair, members of the committee. I'm Melvin Thompson. I represent the Restaurant Association of Maryland, and we are opposed to this legislation as introduced. But we have met with the bill sponsor's office, and we are working on amendments to address our concerns. And based on the feedback that we received from our membership, we have concerns about the burden that such a requirement would impose on many restaurants to keep their allergen disclosure information updated. Ongoing supply chain issues often require unanticipated ingredient substitutions. Many restaurants change their menus often, and restaurants do not control the food ingredient manufacturing facilities where an undisclosed food allergen may end up in an ingredient due to cross-contact or contamination before the restaurant receives it. And these operational complexities can make it difficult for many restaurants to maintain the type of information that this legislation would require. And Delegate Hill even mentioned some correspondence from a restaurateur who brought up these same concerns. And so to address our concerns, we will be seeking amendments to narrow the scope of this bill to apply only to restaurants and similar retail food establishments selling restaurant-type foods that are part of a chain of 20 restaurants or more doing business under the same name and offering substantially the same menu. These are the same businesses that are required to comply with the federal menu labeling law and regulations. And these restaurants and food establishments already have the resources and the capability to comply with menu disclosures. And a similar amendment would be consistent with a food allergen menu law that was enacted in California last year, which applies only to those restaurants and food service establishments that are subject to the federal menu labeling law. And we'll also be seeking an amendment to provide some liability protection for restaurants and food establishments that would be subject to the amended legislation. Thank you very much for your time, and I look forward to working with the bill sponsors and this committee on amendments to address our concerns.
Good evening, Madam Chair and honorable committee members. My name is Sarah Price, and I'm here on behalf of the Maryland Retailers Alliance. We do have several of Maryland's Main Street communities as members, and so I'm here on behalf of these small restaurants that are located in these communities. They are generally small, independent, or family-owned establishments, and they would be disproportionately impacted by the proposal before us today. Based on the feedback that we received from those businesses, they do in fact experience pretty frequent changes to their menus. This might be due to seasonality, if they like to change things up for holidays. It might be rotating daily specials, ingredient substitutions due to product availability, or vendor changes based on just the cost of goods. The administrative layer that would be added by this proposal would be burdensome because these businesses do not have a corporate office that is keeping track of the ingredients, keeping track of the menu changes, and pushing those changes out. We heard from one business that has a total of 13 employees, and it's pretty major to ask them to sit down and make these changes at all times, because we're not just talking about a menu change like printing out a new menu. It's, the food items might change on a week-to-week basis. As Melvin noted, the bill as written does not include protection for restaurants that might be acting in good faith, but are depending on vendors who may not be accurately representing the ingredients in the goods that they're selling. But I believe that with the amendments that have been suggested by the Restaurant Association, I do think that our concerns would largely be addressed. Thank you.
Do we have questions for this panel? Let me start with Delegate Hill, followed by Delegate Rosenberg.
Thank you. Either one of you can answer this question. When the sponsors spoke, they spoke about, a sign. And what I'm not clear on is why it would be burdensome for even a single mom and pop restaurant to have a sign that said, our foods may contain nuts, peanuts, blah, 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 blah. Check with your server for what is current today, which is kind of what people are doing anyway. It just would be a sign instead of asking, why would that not take care of it? And the second part of the question is, we have testimony from the WMDA CAR service stations who are saying that the service stations that serve the pizzas and the various other things, that they shouldn't be excluded, even though they're chains, that they should be excluded from having to list allergies as well. So why is it burdensome for a mom and pop to put a sign saying some of our foods may contain the following things, so please check with us because our foods change daily? And do you think when you say chains that should include chain service stations that have, and then those kinds of stores that serve food, or those restaurants?
Thank you for the question, Delegate Hill. And let me just clarify, according to the bill language, it requires a restaurant to make available to each customer a written disclosure of each main food allergen, if any, that the restaurant knows or reasonably should know is contained as an ingredient in each menu item. And so that's the language that we shared with our members to get feedback of what this bill would require. That's a little bit different than, I think, what was suggested earlier, that a simple sign saying these items may contain.
Person know. It's sharing with each customer.
Right, but this, I'm reading the requirement as the bill language was introduced.
Okay.
On the second question regarding other food service facilities that serve restaurant-type foods, we thought it was appropriate to be consistent with the federal menu labeling law and regulations, and that applies to all restaurants and other similar retail food establishments selling restaurant-type foods, and that does include convenience stores, grocery stores, and other businesses that sell ready-to-eat foods, which are the same types of foods that restaurants serve. And so we thought it would be appropriate for the language in the amendment we're seeking of 20 or more establishments to comply with this, because they already have to comply with the federal menu labeling law, and we wanted to be consistent with that.
All right, thank you. And
Certainly.
good seeing you again.
Same here.
Delegate Rosenberg.
I don't want a comprehensive, which chains are covered by the law and which chains of note are not? I'm not asking for an absolute perfect list, but to give us some sense of who is covered and who isn't by the federal law, which you're asking us to adopt the same standard.
That is correct, sir. And under the federal law, if you are a chain restaurant or similar retail food establishment that is part of a chain of 20 or more locations, and they are under the same name and offer basically the same type of menu items, then you are covered by the federal.
To be in the same state.
Oh, no, this is 20 locations or more in total, sir. Yes.
Okay.
Thank you for clarifying.
You. Sure. That's not what I was going for, but I'm glad to.
Yes, that's who the law applies to.
Thank you, Madam Chair.
I'm looking for any other questions from the members. Seeing none, I have a question, which is, I heard you say that you were happy and willing to work with the bill sponsor. I did hear from the previous panel their desire that this be all restaurants because it is an access issue. So my question is, given that I believe that your reading of the bill as drafted is accurate, that this would have to speak to every single menu item. But if we had that good faith language, if we had clarifying language that a sign or a QR code would suffice, and if we gave the smaller restaurants more time after we've created this framework and after we have seen if it is burdensome, would you be amenable to working with the bill sponsor on potentially amending the bill as described?
Thank you, Madam Chair, for the question. I do appreciate it. I do have to say that we have a government affairs committee within our association, so I would have to take these ideas back to them. They were very firm on our position of why it makes sense to limit the scope to 20 or more, and we've also reached out to those brands that have 20 or more locations who would have to comply with this, and they would be fine with the way that our amendment was drafted as well. And so I'll be happy to take it back to my government affairs committee, but I cannot say here today.
And I would not ask you to put that on record without consulting.
Thank you.
This will go to subcommittee.
Okay.
This concludes this panel. We have one more favorable panel.
Thank you.
So if I can bring Jacqueline Kelly, Adelaide Rorick, and Barbara Hofstein to the table. And you can get started when you're ready.
Hi, my name is Adelaide Rorick, and as someone very close to Sky, I've seen how stressful and dangerous eating out can be for someone with food allergies. There have been times where Sky was unable to order anything at a restaurant. The waiter was unsure about the ingredients in the food. Watching her sit there without a safe option simply because of uncertainty shows how necessary clear allergen labeling is. Because of this, I strongly believe that Bill 181 is critical to ensure that everyone in Maryland with food allergies can safely eat out.
Thank you very much. And just for the record, can you state your name?
Adelaide Rorick.
Thank you. Thank you very much. Next.
Hello, my name is Jacqueline Kelly. As Sky's friend and someone with celiac disease, I understand how difficult and unsafe eating out can be for people with food allergies. I have seen Sky get sick due to miscommunications about what menu items contain on multiple occasions. Because of this, I strongly support this bill to ensure that everyone in Maryland with food allergies can be informed while they dine out.
Good afternoon, members of the Health Committee and Chair Delegate Bagnall. My name is Barbara Hofstein, and I am a registered and licensed dietitian. Today, I come to represent the Maryland Academy of Nutrition and Dietetics, representing over 1,000 registered and licensed dietitian nutritionists in the state. Mand and I appreciate the opportunity to comment on HB 181, Restaurant Disclosure of Main Food Allergens. Mand agrees that food allergies are an important issue to be addressed in restaurants. We would like to add an amendment to the bill, since main food allergies is a list published by the FDA that includes 9 food allergens that must be listed also on food labels. Since there are many more allergies, for instance, I am allergic to tomatoes. It will close my throat. And even a little bit that gets into a sauce will cause an asthma attack. And that's not on the list. And also I'm allergic to berries, which is not on the list. We suggest that all menus state on the bottom of the menu, if you have any food allergy, please inform your server. Again, we appreciate this bill being put forward. Thank you for your attention and consideration.
Thank you very much for your testimony today. Do we have questions from the committee for this panel? Delegate Alston.
Thank you, Madam Chair. Just real quick, when you, Sky's friends, when you all eat out, are you always eating at a national chain, or do you sometimes go to small mom and pop stores that have less than 20 restaurants?
We go to a lot of smaller ones too.
Thank you so much for your testimony, and thank you for coming today. You all did a great job as well.
Seeing no further questions, I just want to say thank you again for your advocacy, and we look forward to when you join us again as a member of this body, because I think that's probably in your future. This concludes the bill hearing on House Bill 181, and also concludes our bill hearings for today. Thank you so much for your patience and for staying here.